With pleasure.
So let's move to the next speaker, Professor Antoine ROQUILLY from Nantes, France, and we're going to talk about the timing of the surgery. Thank you.
Thank you, Pierre. Really appreciate the opportunity to be here this morning to discuss about the timing of surgery. Like Sophie just presented the data earlier, spinal cord injury is a dynamic process. And one of the main goals in our care is to prevent and treat the secondary injury in the spine. So surgery can be a very powerful tool to reach this aim. And the two aims that surgery can help to treat is first the spinal cord hypertension, because this secondary insult is clearly associated with the outcome. And so surgery can really help by doing surgical decompressions. So removing part of the vertebra can help to decrease the pressure in the spinal cord, and so on. We hope to increase the recovery of the patients. The second thing is to help the patients for early rehabilitations, because when you have a dislocations or a bone fracture in the spine, it's very difficult or almost impossible to start early rehabilitations. But we know that surgical stabilizations can help to start rehabilitations early in ICU. And if you can do that, it's associated with a better outcome in the patients. So clearly, surgery will help to decrease the pressures and stabilize the patients. So for some of the patients, there is no question. You will go directly for the surgery. For example, when you have such a break in the spine, on the left pictures, there is no question. On the right side, you can see that it's more difficult because you only have a contusion of the spine and there is no clear fracture of vertebra or dislocations. So let's stick on the left side and say that we decide to do surgery. The question is the timing important to realize this surgery? Is there an impact on neurological recovery, and is there an impact on the risk of complication after the surgery? So everyone is okay with that. Surgery for spinal cord injury is an emergency. But the definition in the literature when we spoke about early and late is this one. Early is usually considered as a surgery realized in the first 8 hours after trauma, while late surgery is performed between the 8 and 24 hours. So most of the patients are operated during the first day. So is early surgery within the first 8 hours associated with the better outcomes? It's still a matter of debate. There is no big randomized clinical trials to respond to these questions, and we only rely on large cohorts of patients. In this study, the authors have shown that realizing the surgery within the first 8 hours was associated with a better improvement in the ASIA impairment scale. So basically, it increases the probability for the patients to go upward and move from a complete deficit to a partial or to a full recovery. But if you look to some other data, for example, in this other study, it's a monocenter study, they analyzed some functional score. So it's a possibility for the patients to be independent in his life. And they compare the same threshold of early and late surgery. You can see that early surgery in pink is a bit better, but it's not significant. But now if you look at the same study and you look at some specific independence score, which are quite important for the patients, like mobility and transfer or bladder management, you can see that patients who have benefit from early surgery are more independent than others. So for sure, surgery after 24 hours is not recommended. And if you can perform surgery within the first 8 hours, it's probably better. But the main fears to realize that is that it's some difficult surgery. It's a 7-day-a-week surgery and 24 hours a day, so it can occur during night. And it's a surgery at risk of hemorrhage, infections, or constrict failure requiring secondary surgery. So one of the questions we have to deal with when we decide to realize early or late surgery is my early surgery associated with an increased risk of surgical complications? Once more, few data in the literature, and here you can see that patients who have with an early surgery have globally the same number of complications, 48 and 49, as compared to late surgery. Probably a small increase in the risk of constrict failure requiring a secondary surgery, but no risk in infection and so on. So if you can have a trained team and you have a patient in good conditions, realizing an early surgery within the first 8 hours is probably associated with a better neurological outcomes, and that it doesn't increase the risk of post-operative complications. That's why the French recommendations released last year conclude that if you have a patient with a traumatic spinal cord injury, an emergency surgical decompression is recommended, and it's not later than after the 24 hours. It's probably better to do that in the first 8 hours, but in some specific conditions, notably if you don't have access to very good, to very trained surgical team, or the patient suffers some other conditions, you can wait. But we have to do our best to go to the surgery early for these patients.
Thank you very much, Antoine. So we have a lot of discussion during the guidelines about the MRI. We wrote something about it, and we say that when we can do it, you have to do it. So why, when you use MRI, does it change something for the patient? Should we wait from the MRI to go to the operating room? What is the exact role of MRI for guiding the surgery, in your opinion, and in the guidelines we wrote?
Yeah, so it's always a matter of benefit and risk. For the risk, MRI is not easily accessible 24 days a week in all the centers. So if you decide to realize an MRI, you know that you will spend 2 to 3 hours to get the exam before, and it can delay the surgery. So if you want to really go to the surgery within the first 8 hours, it's probably not a good thing. But if you look to the cohorts of patients with MRI, in roughly 25 to 30% of the case, realizing an MRI before surgery changed the surgical procedure. So it have a significant impact on the way that the surgeon will work. So the recommendation is to realize MRIs as soon as possible, and just be in mind that you do not need to, you do not have to take any risk for the patients. So if you are ready for the surgery, you have a fracture, cervical translocations, and you don't have easy access to MRIs, you can realize the surgery without MRIs. So you don't have to change. But for sure, if you have a patient with a neurologic deficit and no clear explanation on the scanner, you need to go to the MRI. And at this time, it's an emergency. You cannot wait for a few days before the MRI. You need to get the MRI, because in 30% of the case, you will go directly to surgery after the MRIs. And it's clearly associated with outcomes. So not every time, if you have a clear condition and it's too risky, go directly to surgery. But we need to try to organize better and make it possible more and more often.
Yeah, thank you. That was excellent. I think you raised a very important question that many centers face is, and you mentioned in the end, is organization. Because if this is the ideal sequence, and it's crucial, as you said, it changes the surgical decision in 30% of the time, and we want to make the maximum of patients take them to the MRI, and within 8 hours to the surgery, this is a major organizational challenge even for a trauma center. So how would you, according to what criteria would you decide which patient to take to the MRI based on the CT scan, for example, or what would push you in any case to take the patient to the MRI and then as quickly as possible to the theater?
I think, yeah, the first thing is to have a good organization and the patients brings to an hospital when you can perform MRIs. And the second rule would be to try to do MRI for all the patients with serious spinal cord injuries. And avoid that only if the patient is not stable, so it means that it's too risky because he's suffering hemorrhagic shock, or he has some traumatic brain injury with intracranial hypertension and something else that makes the transfer to MRI too risky. So for these patients, you can skip MRI. So I think the recommendation is clear. If you don't take too much risk for your patients, you need to try to go to the MRI.
I think we forget something very important, maybe a detail, but the surgeon, sometimes the surgeon wants the MRI, and we say, well, the MRI is closed, I can't have the MRI. But the surgeon say, I want the MRI. And you say, well, tomorrow. So it's another 10, 12 hours. And the next morning, the patient is a bit unstable, say, I don't want to go to the MRI. I want you to operate the patient. But the surgeon wants the MRI. So that's real life. And in real life, it's the surgeon who wants the MRI, not the anesthetist.
Yes, that's why I think it's a clear discussion, and that's why we need to bring these patients to some trauma center when these kind of discussions are daily basis. Because if you look at the proof, waiting up to 12 hours after the trauma is probably not the best condition, but it's still acceptable, and the recommendations say you need to perform surgery within 24 hours. So if you want to wait 3 or 4 hours to be in the morning and get the MRI, it's something that can be done. But if you will exceed these delays, probably it's better to discuss with your surgeon and to have a close collaboration with them. So it really highlights the needs to bring these patients to some trauma center, because it will help to have some trained anesthesiologists, trained intensivists, trained surgeons, trained radiologists, and all these caregivers will be focused on these chains and understand that realizing an MRI at 3 a.m. Could be useful in some circumstances, and so you can open an MRI in these centers. So it's really a question of organization for the hospital system, because we need to understand that. So I'm not saying that it's real life. I think we need to trend toward that. And to reach this objective, we really need to have all the patients, or most of the patients, in the same hospital, because we cannot have MRI in all the hospitals in France 7 days a week, 24 hours days. So we need to focus the patients in the good locations when we know that it will be useful, cost-effective for the patient and the society to put MRI 24 days there.
Thomas, you want to?
Yes, I have a question that, not considering the neurological recovery, but just considering that sometimes you have an early window for surgery because there is no pulmonary infection or hypoxia, and sometimes it is also interesting to do the surgery early, just before the complication. What is your opinion for that?
Yeah. These patients frequently present well at the beginning, and we know that most of the severe spinal cord injury, mainly cervical spinal cord injury, will develop complications such as pneumonia, acute respiratory distress syndrome in some cases, and it will be very difficult to bring back the patients to the surgical theater after that. So it's probably a good thing to treat surgery. There are some evidences suggesting that early surgery can prevent this kind of complications. And for sure, this kind of complication will make it more difficult to realize the surgery in a good condition. So it's another good reason to realize early surgery, to be in the best conditions to realize such intervention.
And we talk about the timing of the surgery, not depending on the neurological sign. Is there a difference if you have a complete lesion or an incomplete lesion? Would you manage the timing of surgery differently, meaning that maybe in incomplete lesion you want to go faster to the surgery? What is your opinion about the impact of clinical signs on your clinical or your surgery decision making?
So in the publication showing that surgery within the first 8 hours are better, what they find is that the patient with incomplete deficit will have a better recovery, and for the patient with complete deficit, the difference is less striking. So clearly the benefit is more evidence for patients with incomplete surgery. So for this one, we need to do all our best to get this patient in the surgery within the first 8 hours. After that, we cannot exclude some good recovery for patients with complete deficit, and so the recommendation at this time say that we need to try to do our best even for patients with complete deficit to go early to the surgery. So for sure, if you need to wait a few hours to get an MRI, if you have such a defect like in the first photo, so we are almost sure that there is a section of the spine, you can probably wait because there is no real chance of recovery. But if it's incomplete recovery, you even need more to go faster.
Okay, thank you very much, Antoine. So